Good day, everyone. So, we will be presenting a case study entitled Early-Onset Alzheimer's Disease with Aphasia, a case report. And this will be presented by Ms. Alcayera Altea and yours truly, Garjola Giovanni. So, Alzheimer's disease is traditionally subdivided into early onset and late onset. And early onset has an onset before age of 65 years. And aphasia is defined as a language disorder caused by a damage in a specific area of the brain that controls language expression and comprehension. Dementia isn't technically a disease, but more of a way to describe a set of symptoms like poor memory and difficulty learning new information, which can make it really hard to function independently. And usually, dementia is caused by some sort of a damage to the cells in the brain, which can be form of a variety of diseases. And Alzheimer's disease, now referred to as Alzheimer's disease, is the most common cause of dementia. And also, Alzheimer's disease is considered as a neurodegenerative disease, meaning it causes the degeneration or loss of neurons in the brain, particularly in the cortex. And this, as you might expect, leads to the symptoms characteristic of dementia. And although the cause of Alzheimer's disease isn't completely understood, there are two major players that are often cited in its progression, and these are the plaques and the tangles. So here we've got the cell membrane of a neuron in the brain, and in the membrane you've got this molecule called amyloid precursor protein or the APP, and this APP can be found in the cell and the other ends outside the cell. And this APP helps the neuron grow and repair itself after the injury. And since APP is a protein, and just like other proteins, it gets used and over time it gets broken down and recycled. And normally it gets chopped up by an enzyme called alpha secretase and its body gamma secretase. And this chopped up peptide is soluble and goes away and everything's all good. But if another enzyme, which is the beta secretase, teams up with gamma secretase, then we've got a problem. Since this leftover fragment isn't soluble and creates a monomer called amyloid beta. And these monomers tend to be more chemically sticky and bond together just outside the neurons. And it forms what are called beta amyloid. And this beta amyloid plaques or these clumps of lots of these monomers, or these are clumps of a lot of monomers. And these plaques can potentially get between the neurons, which can get in the way of neuron to neuron signaling. And if the brain cells can't signal and relay information, then brain functions like memory can be seriously impaired. It's also thought that these plaques can start up an immune response and cause inflammation, which might damage surrounding neurons. And amyloid plaque can also deposit around the blood vessels in the brain, and it is what we call the amyloid angiopathy, which weakens the walls of the blood vessels and increases the risk of hemorrhage or rupture and blood loss. And another part of Alzheimer's disease are the tangles. And these are actually found inside the cell as opposed to the beta amyloid plaques. And just like the other cells, neurons are held together by their cycloskeleton, which is partly made up of microtubules. And these tract-like structures essentially act like a minecart shipping nutrients and molecules along the length of the cell. And a cell protein called tau this tau makes sure these tracks don't break apart and it is kind like of a railway ties. And it's thought that the beta amyloid plaque buildup initiates pathways inside the neuron that leads to activation of kinase. And this kinase is an enzyme that transfers phosphate groups to the tau protein. And the tau protein, it changes shape and stops supporting the microtubules and clumps up with other tau proteins or gets tangled and leads to other characteristics finding of Alzheimer's disease, neurofibrillary tangle. And these neurons with tangles and non-functioning microtubules can signal as well and sometimes end up undergoing apoptosis or programmed cell death. And as neurons die, large-scale changes start to take place in the brain. For one, the brain atrophies or shrinks and the gyri get narrower, which are the characteristic ridges of the brain. And as those get narrower, the sulci, which are the grooves between the gyri, get wider. And with atrophy, the ventricles or fluid-filled cavities in the brain get larger. And that is all for the pathophysiology of Alzheimer's disease. For the case, a 60-year-old retired white man, married and with college-level educational background, presented at our inpatient service accompanied by his wife and daughter, reporting complaints of aggressivity and intense agitation. He showed restlessness and disorganized behavior and failed to recognize people or agnosia. He was unable to what was being said or receptive aphasia and did not adhere to clinical orientations or follow instructions given by the team, proving unable to perform basic motor actions. Example, he refused to take the medications prescribed, he grasped the pills and didn't take them. And patients with receptive aphasia has impaired comprehension of their speech. Thus, they may have trouble answering basic orientation questions, and results of complete blood count and coagulogram, biochemistry, renal, liver, and thyroid function tests, vitamin B12 levels, serology for syphilis and anti-HIV qualitative urine tests, urine and blood cultures, 2 samples, CSF profile, and chest X-ray were all within normal limits. Computed tomography of the brain was performed on January 2018, and underlying neurologic conditions were ruled out. For the SOAP analysis, information gathering, patient demographics, age 68 years old, male, economic status, married, retired, height and weight are not indicated. For the patient history, patient medical history, the patient had no history of hospital admissions on surgery. However, at the age of 55, the patient presented cognitive decline with short-term memory impairment and slowed hesitant speech. For the social history, at the age of 55, he was no longer able to remember the way to work. He stopped driving and exhibited spatial disorientation, and he has also a history of smoking. For the review of systems, medication history, and allergies, it is also not indicated in the case. For the subjective information or symptoms, the patient has experiencing a cognitive decline with predominantly short-term memory loss. He tended to forget where he had left his keys and had trouble remembering recent events such as appointments, slowed hesitant speech, exhibited spatial disorientation. He became apathetic and had difficulties taking decisions at work. And based on these symptoms, according to the clinical guideline for Alzheimer's disease management, California, work group on guidelines of Alzheimer's disease management, behavioral symptoms, more than 80% of Alzheimer's disease patients experience some form of behavioral symptoms such as anxiety, agitation, and apathy during the course of the disease. For the objective information, patient information, 68-year-old retired white man. He, he is married and with college-level educational background. For the laboratory test, results of blood count and coagulogram, biochemistry, renal, liver, and thyroid function tests, vitamin B12 levels, serology for syphilis and anti-HIV, qualitative urine test, urine and blood cultures, 2 samples, CSF profile, and chest X-ray were all within normal limits. However, the PET-CT revealed hypometabolism and atrophy in the left temporal lobe and posterior region of the parietal lobes. For the objective informations, medications, the patient is taking losartan, 50 milligrams, rosuvastatin calcium, 10 milligrams, vitamin D, memantine, 20 milligrams, donepezil, 10 milligrams, venlafaxine, 150 milligrams, and quetiapine, 50 milligrams. For the succeeding slides, it will be discussed by Ms. Alquiliera.
Hello, good day everyone. So let us now discuss the assessment. So ang drug therapy problem ay inappropriate compliance at drug interaction. So una, inappropriate compliance dahil si patient based sa case ay hindi sumunod sa mga clinical orientations or follow instructions na binigay sa kanya na nagpapatunay yon na hindi niya magawa yung mga basic motor action. For example, he refused to take medications prescribed. Kumbaga, kinuha niya lang pero hindi niya iniinom. Hindi niya tinitake yung mga yon. Pangalawa is the drug interaction. Patient was taking losartan, rosuvastatin, vitamin D, memantine, donepezil, venlafaxine, and quetiapine. So may drug interaction tayo dun sa donezapin and venlafaxine. It can both decrease QTC interval. So kailangan natin ng monitor doon or ng caution kapag gagamitin natin yung ng sabay. Next is our primary impression. First, at 55 years of age, the patient presented cognitive decline with short-term memory impairment and slowed, hesitant speech. Next, at 57 years, he was unable to remember the way to work, exhibiting spatial disorientation. Sa kanyang PET-CT, it revealed hypometabolism and atrophy in the left temporal lobe and posterior region of the parietal lobes. Next, he became apathetic and had difficulties taking decisions at work and was unable to manage his finances. Lastly, the patient refused to take the medications prescribed. So, yung mga primary impression natin kay patient is ito yung mga symptoms ng dementia or ng Alzheimer's disease. The clinical guideline that we use for this case study is the Guideline for Alzheimer's Disease Management, California Workgroup on Guidelines for Alzheimer's Disease Management. So ito yung agreed to namin para sa ginamit namin clinical guideline. Ito yung mga final results namin sa bawat domain. Now for the list of patient symptoms with treatment goals, number 1 is the cognitive symptoms. The patient was given donepezil 10 milligrams and memantine para sa kanyang mga cognitive symptoms. So the goal of the treatment ng mga drugs na to is to treat dementia or memory loss and mental changes associated with moderate or severe Alzheimer's disease, and to slow the neurotoxicity thought to be involved in Alzheimer's disease and other neurodegenerative diseases. Next is the major episode of psychomotor agitation with risk of aggression. Dito naman, si patient ay he was medicated with haloperidol and midazolam. So itong mga drugs na to, ang goal of treatment nila is it is used to manage positive symptoms of schizophrenia such as hallucinations and delusions. Para naman sa plan, sa pharmacologic therapy, change donepezil to galantamine and remove venlafaxine. So, papalitan natin yung donepezil kasi ito yung may drug interaction sa olanzapine na isa sa medication ni patient nung hindi gumana sa kanya yung quetiapine. Kasi based sa case study, pinalitan ng olanzapine yung gamot ni patient kasi nga hindi na gumana sa kanya yung quetiapine. And we remove venlafaxine naman kasi yung drug na to is used for depression, based sa case niya is wala naman siyang depression. And may interaction din siya sa drug na pinalit natin sa donepezil, which is si galantamine. For non-pharmacologic therapy naman, we advise the patient to have cognitive interventions. So, pwede siyang bibigyan sila ng arithmetic problems or exercises kung saan a series of numbers ay kailangan nilang makumpleto or yung mga pictures is need nilang maalala at makilala. Meron din namang mga exercises like words and puzzles as well as interventions kung saan yung mga pang-araw-araw na gawain ay gagawin nila. Yung mga ganitong klase ng exercises is pwede nilang gawin either one-on-one or group sessions. So, another intervention na pwedeng gawin is reality orientation training. Itong approach na to, itong intervention na to, it aims to help improve people's orientation sa space and time. So, ang ginagawa dito is paulit-ulit sila na binibigyan ng basic information such as their name, the date, or the time na yung mga people with Alzheimer's. Ginagawa to in conversations or by placing orientation aids around the person's home, dun sa bahay ng may Alzheimer's disease. So itong orientation aids, it might include things like calendars or door signs or with the names of the rooms on them. Next is the physical, emotional, and social stimulation. Dito naman, it focus on different types of activities gaya ng discussion group sa mga various topics, preparing meals together, practical things gaya ng pagbrush ng teeth, pagtimpla ng kape, or pagsulat ng letters. But also physical activities to improve strength, endurance, and balance. Pati na rin ng art and music is ginagawa natin dito sa physical, emotional, and social stimulation. Meron ding mga research na nagpapakita ng social activities is kayang makapag-improve ng quality of life ng mga taong may Alzheimer's, pati na rin yung family members nila. It can help people with Alzheimer's na ma-prevent nila yung apathy. And mababawasan din ito yung need nila for care. Kasi matututo sila na i-handle yung sarili nila, alagaan yung sarili nila. Just like with other people, yung mga physical activities is may health benefits din yan para sa mga taong may Alzheimer's. So, importante na ma-ensure yung mga older people that they're able to stay active para hindi din sila ma-bedridden. Next is the emotion-oriented interventions. So, ito naman, syempre from the word itself, it focus on the feelings, values, and experiences ng taong may Alzheimer's disease. And it aims to improve their quality of life. So, isa sa mga example nito is validation therapy. So, sa therapy na to, yung mga caregivers is gumagamit sila ng special communication techniques kung saan nagbibuild sila ng closeness and care kapag nakikipag-interact sila sa mga taong may Alzheimer's. So, ginagawa natin to sa kanila para syempre maramdaman nila na naiintindihan natin sila, na pag nag-open up sila, safe yung mga sinasabi nila, and maging comfortable sila sa atin. And hindi rin sila ginajudge, syempre, lalo na sa mga behavior na pinapakita nila and tinatanggap nila kung ano yung feelings nila. And meron ding isa pa na reminiscence therapy. So, it is another kind of emotion-oriented treatment. So, alam naman natin, di ba, na kapag na Alzheimer's is mahirap makatanda ng mga bagay-bagay. Kaya meron tayong ganitong therapy. So, sa reminiscence therapy, people who have Alzheimer's are encouraged na pag-usapan yung mga topics such as their hometown, school days, or work. So, ginagawa natin to in individual or group settings. Siyempre, ang goal natin dito is to improve their mental abilities, pati na rin siyempre yung quality of life nila. Hindi talaga yun mawawala. And para malesen na din yung psychological effects ng Alzheimer's disease. And also, research suggests na yung reminiscence therapy, it can have a positive effect on mood and mental performance. Next is ang ating caregiver training programs. Siyempre, sa mga caregiver, kailangan meron din tayong mga ganitong training or programs. So, itong program na to, it aims to teach them how to help people who have Alzheimer's para makip nila yung abilities nila for as long as possible. Para na rin maintindihan nila yung disease better and solve practical problems related sa pag-aalaga sa mga taong may Alzheimer's or sa mga mahal nila sa buhay. And research has suggested that people with Alzheimer's can live at home for a longer time if yung mga caregivers nila is magkakaroon ng ganitong training programs. Meron din mga some evidence na nagsasuggest na special training in how to deal with challenging behavior has a positive effect, and it could help to reduce challenging behavior such as aggression and restlessness, and also help caregivers na makapag-cope doon sa kind of behavior na ipinapakita ng mga taong may Alzheimer's disease. Siyempre, importante yun para sa mga hindi naman talaga caregiver na 'di ba, bigyan sila ng suporta at tulong para mas maintindihan nila yung kailangan nilang gawin and yung mga taong may Alzheimer's din. Para kapag napunta sila sa mga sitwasyon na stress talaga sila ay nakaka-upset, alam nila yung gagawin nila and alam nila paano i-handle yung ugali ng mga taong may Alzheimer's. Lastly is yung diet. So, some experts naniniwala sila ng pagkain ng mga healthy diet is makakatulong siya na makapag-prevent or slow down ng Alzheimer's. Ito yung tinatawag nila na Mediterranean diet. So, it is supposed to have a positive effect sa memory and cognitive abilities ng mga taong may Alzheimer's. And itong diet na to, it includes a lot of vegetables, fruits, nuts, olive oil, whole grain, and fish, tsaka poultry. So, ayan yung mga included doon sa Mediterranean diet. Pero let us all understand and remember na wala talagang cure. There's no currently cure para sa Alzheimer's disease. Pero meron tayong mga medicines na available that can temporarily reduce the symptoms. And pinakamahalaga talaga is yung pag-aalaga natin, suporta at pag-intindi sa mga taong may Alzheimer's at pati na rin dun sa pamilya ng mga taong may Alzheimer's para makapag-cope sila sa everyday life and mas maintindihan nila yung pinagdadaanan ng mahal nila sa buhay na may Alzheimer's disease. So that would be all for our case study presentation. Thank you so much for listening.